Zaczynamy od prezentacji pana profesora Theoharidesa, który jest moim wielkim guru i wielkim autorytetem od bardzo wielu lat. Pan profesor Theoharides opowie nam o zapaleniu w mózgu i o roli komórek tucznych w tym zapaleniu. Zapraszam.
Good morning, everybody. Thank you so much for coming. There's a lot to discuss. I will try to make it as simple as possible, and everything I will talk about, including all the slides and all the publications, can be found at that website. So I will be talking about both research findings that might give us an idea about what happens, as well as potential treatment approaches. We still don't understand what autism is, and I just wanted to say that I am on the advisory board of the Mastocytosis Society, and I will talk about mastocytosis, and on a company that makes some supplements. This is a review that we published in the British Journal some years back, and anything that is shown in red indicates that there are many more publications about this problem. So, there are very good correlations between allergies and asthma during pregnancy, low vitamin D, autoimmune diseases, especially psoriasis, and stress. In other words, if a mother during pregnancy has these problems, there's epidemiological evidence that the child may have a higher risk of developing autism. And after delivery, if there's high fever, infection, low birth weight or prematurity, and lack of oxygen, those increase the chances of a child having autism. That does not mean that if all of these are present, a child will necessarily have autism, but we now worry about these conditions and therefore pay more attention to a child earlier on. We will talk about inflammation, and we use the word inflammation without necessarily understanding, even within medicine, what it means. Because there are different types of inflammation, and some examples are, if you have systemic interleukin-1, we call it cryopyrin diseases or Mediterranean episodic fever. If you have global inflammation, we call it encephalomyelitis. If you have inflammation in the meninges that covers the brain, we call it meningitis. If you have inflammation against the myelin, we call it multiple sclerosis. They're all different, however. And I will try to convince you that it is inflammation in the part of the brain that regulates homeostasis, called the hypothalamus, where we should be focusing, that might explain the problem. Now, how do you recognize inflammation? And I'm sure other colleagues can look at different molecules. What I want to stress with this slide is that I like to measure pro-inflammatory molecules and anti-inflammatory molecules, and if the ratio is different, I pay more attention to that. In other words, if some of these are very high and some of these are very low, that is actually worse in my mind than just having one of these values being high. And then there are other molecules that could be added here, such as MCP1 or chemokines, such as interleukin-8, interleukin-5, etc. So this is just an indication of how I try to approach inflammation, because in certain types of inflammation, none of these molecules are high. So if someone had very high TNF and very low IL-10, and Magdalena yesterday actually showed that in her series of children, that was true, that would be worst in my mind. Now, there are also additional types of inflammation, because medicine comes up with names that sometimes are very confusing. So this is a new name, chronic inflammatory response syndrome, but unlike other types of inflammation, in this particular case, it is all toxins. And we have to be very careful, because toxins are very important because they cannot be measured easily. If you have an infection, you can do all kinds of tests, some better than others, but if it is toxins, it is very difficult to measure. And specifically, I will focus on just 2 slides on mycotoxins, because these are toxins that are volatile. In other words, you can go into a home, it might smell that it's moldy, you don't see any mold, but the mycotoxins are everywhere. And in fact, this journal, Clinical Therapeutics, which is online, just this week has a special volume on mold and immunity. I wrote this editorial, and we also have a publication in this volume about effects of mycotoxins on neuropsychiatric symptoms and immune problems. We will be hearing more and more about this. Now you might say, why is this relevant to autism? Well, here are some studies, not from us. One study that was shown actually yesterday too was about 250 children or so in Poland that had not a diagnosis of autism, but very serious cognitive problems, and they were actually due to the fact that they were growing in mold-contaminated homes. There are other studies showing that there's cognitive impairment if you're exposed to mold, and these are 2 very recent studies showing that mycotoxins are involved in the pathobiology of autism, and this was an epidemiological study showing association between mycotoxins and autism. So we really have to be very careful. And as I will try to show you very soon, is that once you have a trigger, then the immune system, especially the cells that I will talk about, become super sensitive, and that additional triggers make things worse. But at the end of the day, how does inflammation happen in the brain? Does a bacterium get into the brain, or a virus? Do inflammatory molecules get into the brain? And how will they get into the brain? That is what got us very interested, because inflammation has been known to create problems in the brain. But for some reason, colleagues did not believe this at all until very recently. You can see studies from a long time ago talking about inflammation during neonatal or fetal life causing problems, maternal autoimmune diseases, asthma and allergies. This was one of the largest epidemiological studies, about 27,000 children that showed a connection. And maternal immune activation, this was mostly in animal models, and that other colleagues, especially Judy, have shown that certain cytokines are high both during gestation as well as early in life. Now, none of this necessarily tells you that a child will have autism. But again, these are signs that we should be watching for as early as possible. So we were fascinated by this cell type called the mast cell, and in 1990 we wrote a review that it might be the immune gate to the brain. Why? Because if you make a cross-section of a blood vessel in the brain, and this is from our own laboratory, you can see a red blood cell, the endothelial cell, and a pericyte. The endothelial cell and the pericyte make up the blood-brain barrier that protects the brain. But there is a mast cell all around embracing this. So the mast cell, the endothelial cell, the pericyte. Now, mast cells, as you will see shortly, and as you know, are involved in allergies. Why are they in the brain? Allergies do not affect the brain, or the brain does not get allergies. And I will try to convince you that these cells are very important, especially in the part of the brain called the hypothalamus that regulates body functions, and the amygdala that regulate emotions. If you measure or count the number of mast cells in this part of the brain, you have more mast cells than you have on your skin. So obviously they're very important for regulating what goes in and out the brain, and that's why we wrote a number of papers about focal or localized inflammation in the brain, unlike the generalized inflammation that I mentioned earlier, that has different names and affects the whole brain. Now, over the last few years, there have been very good information that the defenders of the brain, called microglia, are involved in autism. Just to refresh your memory, the white blood cells that circulate in the blood do not get in the brain. They should not get in the brain. If they get into the brain, they recognize it as foreign and they attack it. That's why you get sclerosis en plaques or multiple sclerosis. And the brain has its own defenders, the microglia, to do the job. But the microglia are not as smart as some of the white blood cells, in the sense that they respond similarly to various triggers, while the white blood cells are somewhat more generalized and specialized. We have T cells, we have subclasses of T cells, etc. The microglia mostly are type 1 and type 2. The type 1 are pro-inflammatory and the type 2 are mostly protective. So we made the hypothesis that if the mast cells in that part of the brain are activated, they will release molecules that activate the microglia. The microglia will release pro-inflammatory cytokines and chemokines, and it will cause a localized inflammation. It's like your spark plugs in your car are rusted and it just doesn't work anymore. So we have somehow to clean up that area and help the brain cells. And there are many colleagues who have written about microglia and mast cells and neuroinflammation. It's not just us. But when we proposed it almost 10 years ago, no one believed that that is true. And now more and more reviews are talking about it. And in fact, a recent review speaks about induction microglia activation by mediators, molecules released from mast cells. So there's more and more information supporting this possibility. Oops. Somehow I'm frozen. I cannot move the slides either from the computer or from here. This one. Oh. Sorry about this. Okay, now it moved from where? Let me see if it moves from here.
Yeah.
This one. Okay.
This one.
Okay, I'll try that. Thank you so much. So we first asked the question, are there any molecules that trigger the mast cells that we can measure in the blood of children with autism? So in these two studies, we measured about 20 different potential triggers, and only one molecule called neurotoksyne in a group of children in Greece and a group of children in the United States shows that in about 50% of the children this is high in the blood. And we also measured the first hormone released under stress called corticotropin releasing hormone or factor, CRH or CRF, and that was actually very high. So we had two potential markers. So then things became a little more complicated because not only both markers were high in the blood, But if we actually gave both markers together, corticotropin-releasing hormone and neurotensin, to cultured human mast cells, they released a lot of a molecule called vascular endothelial growth factor, and the more CRH, the more we got. This is actually very vasodilatory and opens up the blood-brain barrier, and this was published in the Proceedings of the National Academy of Sciences. And things become even more complicated because if neurotensin stimulates the mast cells, they grow receptors for CRH, and if CRH activates the mast cells, they grow receptors for neurotensin. So you see that the mast cells start becoming more and more sensitive to additional triggers. So then we said, okay, is it just the mast cells or is it the microglia as well? So we cultured human microglia from people that have died, and we showed that the microglia in the children with autism, you see the green, have receptors for neurotensin, while the controls do not. That means that the microglia respond more to neurotensin. And if they respond, what do they secrete? Well, we measured interleukin-1 beta, a major inflammatory cytokine, and as you can see, whether we use two types of microglia cultured, we got a lot of IL-1 beta. So in the brains of children with autism, the microglia have more receptors and are likely to respond more to neurotensin releasing interleukin-1, which will cause localized inflammation. But as I said, the mast cells are primarily known for allergies. So we asked, could, for instance, autism be a type of allergy in the brain? And in fact, there have been publications showing that allergic responses are high, at least in this case, in Asperger's syndrome, and I'll show you more publications. And it is very important that this is the cover of the European Journal, Pediatric Allergy and Immunology, showing that during pregnancy, the mother is exposed to a lot of things that will definitely affect the fetus. I don't have time to go into the specifics, but there are at least 3 very good publications that if the mother is seriously stressed during pregnancy, the child will become more allergic, even though the mother was not allergic. So this is fascinating. Just the stress alone will make the child more allergic, and that might be one of the main problems, in addition to others, that might contribute to autism. It's frozen again. I tried either one. Okay. It's the magic touch of Magdalena that does it. There have been very large epidemiological studies showing that if children have allergies, they have behavioral problems. And you see here they call it allergy, here they call it atopy. Atopy is a more general term. If you are not allergic to a specific allergen, but you respond to heat, you respond to stress, we call that atopy. And here, comorbidity of atopic disorders with either autism or attention deficit hyperactivity. And here's possible relationship between allergic manifestations and autoantibodies against the brain, which are present in about 30% of the children. So very large studies support this hypothesis that I presented. So how do we actually identify atopic diseases? Well, in my mind, if I see a child that has black circles under their eyes, we call this allergic shiners. 90% they'll have allergies. I don't need anything else. I need to look why they have these problems. And if I scratch them, either on the back or the underarm, you get dermatographia, which is called a derriere sign. That means that the mast cells respond to the pressure. That's not allergy. Okay? So the mast cells respond to a lot more things. Now, there are a number of things that we can measure to find out why you have allergic-like problems. But I want to stress that even though in allergy we talk about IgE, IgG4 is very important, and here's a recent paper talking about increased IgG4 in children with autism. That alone tells me that the children are responding not necessarily to allergens, because allergens require IgE, but to different molecules. And at the end of the day, the easiest and maybe most important way of identifying if there are atopic problems is to collect either 24-hour urine, which of course in children is very difficult, or first morning urine. And in fact, there are diapers for children that allow you to collect the urine. And then you measure either the breakdown product of histamine, which is methylhistamine, or the breakdown product of prostaglandin D2, which is 17-PGF2-alpha. This is a little tricky for young children because the urine has to be cold and it has to be sent to the laboratory cold, otherwise the results are negative. Now, is there any more information that children with autism have allergic-like problems? This was one of the first studies where they looked and showed that food intolerance, not allergy, was very high in the children. And then subsequent studies spoke about immune conditions, co-occurrence of autism and asthma. This was about 20,000 children from California, and the only association with autism was asthma and allergies. And this was a very large study that was done showing that atopic dermatitis or eczema was actually associated with autism. All of these conditions mean that the mast cells are activated. So what are the mast cells? We published this in the New England Journal of Medicine a couple of years ago about mast cells, mastocytosis, which is a condition where you have too many mast cells that are very hyper. And a mast cell looks like a soccer ball with about 500 ping pong balls. And if it is activated, it can release everything. And you see, these are granules that are releasing the content. This is the nucleus. But back some years, in 2009, we published a study showing that if children had mastocytosis, the risk for autism was 10 times higher than the general population. That is what really got us very interested in the atopic symptoms and autism. And this is from the New England Journal of Medicine that shows a mast cell in the middle, and it responds to drugs, bacteria, viruses, toxins, peptides from the brain, molecules from the immune system, and all of these are not allergies, because these are not allergens. So we have to stop thinking that the mast cell only responds to allergens. And this is also taken from the New England Journal of Medicine, showing that depending to what the mast cells respond and what they secrete, they can affect every organ in the body, including the brain. So we have to be very critically thinking that if a patient, a child, has anything that is reminding us of allergies, we really have to actually address that soon. Now, why do the mast cells respond to non-allergens? For instance, they have what they are called TLR, or toll-like receptors, and they respond to borrelia that are important in Lyme disease, and they respond to fungi. And what is very important to keep in mind, this is not degranulation that happens in allergy. There's only cytokine release. And here, interleukin-6 and TNF-alpha. So the mast cells can respond and release cytokines or chemokines without necessarily histamine. So measuring histamine would be irrelevant in at least certain cases. In addition, the mast cells respond to heavy metals such as mercury and aluminum, and they respond to various herbicides, of which we worry because glyphosate and atrazine are the most common herbicides in the world. So if you eat basically food that has either glyphosate or atrazine, in addition to what these molecules can do directly to your brain, they can also activate the mast cells. So as a summary, the mast cell can respond to allergens by degranulation, going from this to this, very quickly, and releases histamine and leukotrienes. So for histamine, we have antihistamines. For leukotrienes, we have singular. But again, these are not relevant necessarily in autism. Where the action is molecules listed here that can be released from the mast cell without degranulation, so it will be very difficult to identify. Now, we were very fascinated to find out that the mast cells do one more thing that I didn't know at all about. If we stain the mast cells for mitochondria, this is confocal microscopy, the mitochondria are found around the nucleus. If, however, we stimulate the mast cells with a peptide, the mitochondria start moving away from the nucleus, and we never knew that they can move, actually. So we wanted to find out what happens. So we took a biopsy from the skin of a normal individual, and you can see the nucleus, the mitochondria very close to the nucleus, and the granules intact. They have not released anything. If you take a biopsy from a patient with eczema, you can see a lot of the mast cells are releasing their content, and now the mitochondria are not close to the nucleus. Here's the nucleus. They're very close to the cell surface. And we said, is it possible that the mitochondria are releasing anything to the outside? So we measured mitochondrial DNA, and to remind you, the mitochondria have their own DNA, different than the nucleus of the cells, because mitochondria were bacteria that became symbiotic with our cells millions of years ago. And we find that when we stimulate the mast cells, there's a lot of mitochondrial DNA coming out. So then we ask, well, if mitochondrial DNA is coming out, what will it do to the body? So we took mitochondrial DNA, we added it to different cells, and they all got activated and induced inflammation. So when mitochondrial DNA is released, the body thinks that it has an infection because mitochondria were bacteria, but there's no infection. So it's literally an autoinflammatory disease. And there are a number of papers showing that that actually causes problems. So then we said, let's go back to the children. Can we measure mitochondrial DNA in the blood? And as you can see, mitochondrial DNA and anti-mitochondrial antibodies were much higher, basically, in the children. And we then went on to show also that if you add mitochondrial DNA and the first hormone released under stress, CRH, you can actually cause problems, and we can inhibit this with the flavonoid luteolin that I'll tell you about shortly. So, there are indications in the blood of the children that there is inflammation, and there are peptides, and in fact, if we can measure all of those, as you will see shortly, we can identify a subclass of children, about 50%, that will do much better with treatment than other children. So, as a summary, the mast cells can release through degranulation and without degranulation. They cause inflammation so that white blood cells now can enter the brain. And we published a number of papers about mast cells and inflammation and mast cell activation and autism. So what can we do now? Let's assume that every child has inflammation in the brain. For many years, we have been studying a class of molecules called flavonoids, which are found in nature. There are about 3,000 flavonoids, but not all of them are good. And we focus primarily on luteolin or tetrahydroxyflavone, 4 hydroxy groups. This is a very busy slide, so I'll spend a few more minutes describing it. Now, in addition to what I will show you, other colleagues have shown the luteolin is both anti-inflammatory and neuroprotective. So it's very good. And in fact, we've shown that it inhibits inflammation. I will show that it inhibits mast cells. I will show you that it inhibits microglia as well. So it really does everything we'd like it to know. Now, I want to stress, however, that there are many supplements that might contain either luteolin or quercetin. Quercetin is just like luteolin with one more hydroxy group. So quercetin is pentahydroxyflavone. But the cheapest source of quercetin or luteolin is from peanut shells. But they don't tell you that when you buy the supplement. So if you're allergic to peanuts, you're going to have serious problems. And the second cheapest source is actually fava beans, the green kind of beans. And if you are Mediterranean, whether it's you're Italian, Greek, or whatever, about 20% of the people lack an enzyme, G6PD. If you lack the enzyme and you get anything from fava beans, you're going to get hemolytic anemia, and no one tells you that either. And I've seen recently some preparations of luteolin. They don't tell you how much it's in it. And I asked, and I was talking to a physician actually yesterday here as well, and I said, when you open it, what color is it? And they said, white. Well, it doesn't have any luteolin in it, because luteolin and quercetin are yellow. Even if you have 1% quercetin or luteolin, the preparation will be yellow. So if you buy any supplement and they're telling you there's quercetin or luteolin, you open it, and it's not yellow, they're lying. So you have to find, as patients or parents or physicians, a better way to identify what is safer. And I will say something about this shortly. So we actually did first a study where we used mast cells, stimulate them with a peptide substance P. We measured the release of an enzyme as an index of degranulation, and we pre-treated them either with a drug called cromolyn, which is available. It's called a mast cell stabilizer, but as you can see, it inhibits only a little bit. Or we pre-treat them with luteolin, and you can see how much inhibition we get. And also a molecule that is a little better than luteolin, which I don't have time to describe today, called methoxyluteolin. So at least we knew from this that the luteolin can inhibit the mast cells. So I helped formulate basically a supplement called Neuroprotect, which has luteolin, a little bit of quercetin, and a little bit of rutin, and I'll explain why it has those components. And a study was done. It was not double-blind, it was open, and as you can see, I'm not an author, so there wouldn't be any conflict since I helped design this. And I will come back to this. Basically, this was one of the slides from the study showing that depending how much you gave, you had actually either some improvement, or if you double the dose, you had much more improvement. From this study, which lasted 6 months, 1/3 of the children did very well, 1/3 of the children got a little better steadily, but 1/3 of the children did not respond. They didn't get worse. So I'm not saying that this necessarily or luteolin will treat everybody. But as you will see, if you can identify inflammation, those are the children that respond better. And I'll show you the results. Now, why do we add quercetin and rutin? Because rutin is quercetin glycoside. That's how it's found in nature. It's quercetin and a sugar attached. And it's broken down in the intestine. So since many children with autism have a lot of gastrointestinal problems, I wanted to include rutin so it connect locally in the intestine. Now, why did we add quercetin? Because quercetin is broken down in the liver faster because it has more hydroxyl groups to hopefully allow luteolin to escape and get into the brain. You know, it's not accurate, but that's as good as we can actually come for a dietary supplement. Now, what I want to stress also is that unlike many supplements, it lists exactly what it has. It has no allergens, no coloring, and as you will see shortly, it has a certificate that very few actually supplements have from the American FDA. Oops. Magdalena, I need you again. Okay. This is a very important slide, although it might look complicated. From the clinical study that I mentioned a minute ago, they sent us the bloods from the children from time 0 before the study started, and at the end of the study, blindly. We did not know anything. And we measured either interleukin-6 at the beginning, and you can see it's much higher in the children with autism, or we measured tumor necrosis factor, and it was much higher at time 0. So this is time 0. But at the end of the study, you can see that IL-6 is much lower even than the controls, and TNF is much lower even than the controls. So we were fascinated. I really don't know many substances or drugs that can reduce levels of interleukin-6 and TNF. So I wrote to my colleagues, and the colleagues in that case was Dr. Francis and Dr. Talia, and I said, could you tell me how did these children do? Because here, they're dots. I did not know what the children were. And these were the children that did much better with the study. So in other words, if we were to measure ahead of time levels of interleukin-6 and TNF, and potentially other molecules such as MCP1, etc., we might be able to identify about 50% of the children that are more likely to respond well to this particular supplement. So, as a summary, we believe that at least neurotensin, maybe together with CRH, together with mycotoxins and other triggers, activates the mast cells, or the microglia, or the neurons directly, or the mast cells release molecules that activate the microglia, then they activate the neurons and they disrupt connectivity, so that now the child cannot function very well. And as I said, we have found, we've given, in addition, there are 2 clinical studies published with this formulation, and I personally have given to about 5,000 children so far. And for adults that might have also brain fog, which sometimes we see in chronic fatigue syndrome, we see in Lyme, we developed another supplement that still has luteolin, but it has also berberine, which is antifungal and antibacterial. Now, I want to stress this particular document here. In the United States, as in many countries, the regulatory authorities, in this case the Food and Drug Administration, cannot regulate supplements. There's a law of 1974. If, however, you want to export it, only for export, then if you ask the FDA to test it as if it were a drug, and you pass basically all the qualifications, they give you this certificate of free sale that has Department of Health and Human Services, FDA, and it's renewable every 2 years. And these supplements have this certificate. It's very important because that means that they're made in a good manufacturing practices facility. An independent laboratory measure how much you have in it, they know the purity, etc. And for those of you that like the importance of patents, Over the last 3 years, I've been awarded 3 patents about anti-inflammatory compositions for treating brain inflammation in general. That includes actually Lyme and chronic fatigue, as well as 2 patents about diagnosing and treating autism based on combination of molecules such are found in that particular supplement. Okay, so summarizing, and I only have 2 slides or so left, we think that in the hypothalamus and the amygdala, mast cells are activated, they talk to the microglia, inflammatory mediators are released, and there is damage to connectivity. And we published a review in Translational Psychiatry, which is published by the journal Nature, talking about atopic diseases, inflammation, and autism. So if you were to ask me, how do I think about risk for autism? I would say that in the general population, it's whatever it is. If, however, you start having triggers, things become a little more difficult. If you have atopic problems in the mother or the child, the possibility increases. If you now have a lot of stress and molecules are released from the brain, it increases even more. And I don't have time to talk about it now, but there's a molecule called mTOR that activates both mast cells and microglia. If this is activated, then things become even worse. And we have 2 papers in the Proceedings of the National Academy of Sciences. The luteolin blocks mTOR. But again, I don't have time to go into it. So, 2 slides. What would I do for a child that has, let's say, allergies and autism? And this is pretty much, what I do. Again, it may vary. First of all, I need a very good medical history. And I have found that in many children, maybe 1 in 20 children or so, there is either inflammation in the pituitary or hypophysis or a pituitary adenoma. And usually if you do an MRI with contrast, you can actually see that. Or I want to make sure that there is no mast cell activation along of what we've been discussing. Clearly, if there is allergic-like or atopic-like problems, I want to avoid allergens. Colorings are horrible in drugs, in whatever, in foods, etc. I'm sorry. The children respond very badly to odors, especially perfumes. We have found they respond even to clothes that have been sprayed with flame retardants, especially blankets and carpets at homes, and histamine-rich foods. There are many foods that have histamine that doesn't come from the mast cells. So ripe avocado or tomatoes, cheese, sardines, spices, all of those have histamine. And if there is histamine there, I'll tell you the next slide what to do. And avoid preservatives, stress, which could be loud noises, bright lights, etc. Now, here I will only mention some supplements and drugs. Obviously, every one of you as physicians can decide, what to do. And again, all of the slides will be available on my website anyhow. If a child or an adult has been exposed to mold, I give them caprylic acid. It's a natural supplement. It's very good. It has no side effects. If they have inability to break down histamine and they respond to histamine-rich foods, then I give them diamine oxidase, which is an enzyme like pancreatic enzymes and helps you destroy the histamine, at least in the intestine. I give everybody Neuroprotect, but I start slow, usually 1 capsule for a few days, and then I build it up. And even though we say 1 capsule per 10 kilogram weight, I never go more than 6 capsules. Because if I need more than 6 capsules a day, then something else is going on that I have to identify. Because that is not enough to block all allergic reactions. If they cannot sleep, usually I would give them melatonin. Some people do well, some children don't do well. And there are many studies showing that there is deficiency in vitamin D3 in the children, as many as 40%, even in Greece and Cyprus where there's a lot of light. So I give everybody about 2,000 units of vitamin D3 per day. Now, drug-wise, clearly if there are allergic problems, you need an antihistamine. But some antihistamine are better than others, at least in my experience. Cyproheptadine is both antihistamine 1 and anti-serotonin, and it's extremely good for headache prophylaxis. I give it to adults all the time. The only side effect to remember is that you tend to eat a little more and put a little more weight. But as you know, children with autism are very difficult with foods. So if we can increase their appetite a little bit, that's not necessarily bad. Another antihistamine I like a lot is hydroxyzine. I give it at night because it's also a little bit anti-exciting, and all of the children are very anxious anyhow, especially if they had a difficult day. In adults or older children, they might be reaching, let's say, puberty or adolescence. They might be depressed because they cannot socialize very well. I might give them doxepin. It's an old antidepressant, but it's both anti-H1 and anti-H2, and it's also a little appetite stimulant. If there is high prostaglandin, or if they have edema, they swell up, if they can tolerate it, I will give them either aspirin or ibuprofen. I always give children a histamine 2 receptor antagonist because they're stressed, so their stomach will be affected, and they might actually be hurting, and they'll never be able to tell you, especially if they cannot speak. And finally, if there is a lot of stress, and I see stress in literally every child, 90% of the children I see are hyperactive, and yet hyperactivity is not part of the diagnosis of autism. As you know, the diagnosis is difficulty in socializing and communicating. So what do we do about hyperactivity? Unless I can actually slow the child down, nothing really works. So I start and I try to tell the parents, sure, it's a drug, but don't worry about it. So propranolol is a very old drug. It's a beta blocker, but it's very anti-anxiety. In fact, I give to students who are worried about taking an examination because it does not affect your mental abilities. I would not give it if someone has asthma. It's contraindicated. But other than that, you can start at 10 milligrams and you can build it up to 40 milligrams a day as long as the blood pressure doesn't drop, very much. And finishing, these are the students and postgraduate students that worked on this and other aspects. They have all graduated, and it's very difficult to get new people to get excited about autism because there's no money in autism. All of them have gone into the industry or other positions. Most of the work that I told you has been funded by small foundations, and I usually don't show the next two slides, but I decided to put them in because I was surprised and I'm proud of it. So you probably recognize Jenny McCarthy. She's written many books. She has gone on Facebook saying that her child has been taking Neuroprotect for the last 4 years. So it's not my saying so, it's with her permission that I show the slide. And then one child that has both allergic problems and autistic-like problems, whose mother actually put the next slide on social media, and I was not actually aware of it. Oops. And this was that. So this is Brianna. In fact, she visited my office just before coming here. I was one of the first children that has both allergic problems and autism. And basically, you don't have to read all of this, but the mother is saying, we just need physicians to pay attention basically to the whole person and not necessarily to individual symptoms. Thank you very much.
Profesor Theoharides za chwilę nas opuści, bo ma samolot. W związku z tym, jeżeli mają Państwo jakieś pytania, to zamiast zostawiać je na koniec, możemy je zadać teraz. Zapraszam. Zapraszam, proszę podejść. Trzeba podejść do mikrofonu.
can translate if you want.
Tak, ja przetłumaczę.
Yeah.
Tutaj była mowa o ibuprofenie, podane jako przeciwzapalny.
Spoke about ibuprofen. Ibuprofen. 200 milligrams per day.
So
She doesn't want to be sure whether 200 milligrams per day.
yeah. The answer is per day, but as I said, these were just indications because a child or an adult might need less or more. So I don't want anybody to think that whatever I wrote there is exactly what one should give. Okay? For instance, children that have asthma, cannot do very well with aspirin and drugs like that. So I would start a child with a pediatric dose, whatever dose exists in Poland, and then I will look at the symptoms. If they had a lot of edema and starts going down, it will be good. In the United States, Dr. Trifinetti and some others like to give, and I agree with them, a lot of antihistamines and ibuprofen in children that we identify as pandas or PANS. So these are children that do worse with infections, so they have many infections. So that's a separate group where I would give higher dosages.
Trzeba podać oczywiście dużą dawkę, o wiele większą niż ta, która jest przeciwzapalna, nie mająca przeciwgorączkowa.
Because she heard that in order to get into microglial cells, the dose has to be really high, much higher than the dose which is anti-inflammatory and antifebrile.
Dlatego się zdziwiłam, że 200 mg dziennie.
So the answer is twofold. First, there have been studies using ibuprofen or aspirin, even at high dosages, by themselves that don't really do anything to autism. Okay? So therefore, I wouldn't necessarily just increase the doses for autism. I would increase the doses if there are symptoms that tell me that aspirin is likely to help, such as edema, for instance. And then you can increase the dose. But as you know, if you increase the dose, you're going to have gastrointestinal problems. So then I absolutely have to give ranitidine or famotidine to cover the stomach. Every patient, as you know, is different, and you just have to be the judge. But I agree, higher dosages are likely to be more helpful. Oh, there.
Dziękuję bardzo, panie doktorze. Chciałam tylko zapytać, bo zainteresował bardzo ten suplement, który pan proponował neuroprotek. Czy mogłam zapytać, jakie pan zaleca dawkowanie tego suplementu?
Opakowanie? Ewa, przetłumacz.
What is recommended dosage of neuroprotek?
Okay, so as I indicated, I start with 1 capsule per day for a few days, and then 1 in the morning and 1 at night. Now, many children, even though the capsules are very small, many children cannot swallow them. So most parents will open up the capsule, and there's a good and a bad thing about opening up the capsule. When you open it up, it's actually thick yellow liquid. So it's yellow because of the quercetin and luteolin, and it's liquid because it's mixed up with olive kernel oil to increase the absorption. It is not dissolved in water, so you have to actually put it in some food. It can be yogurt, it can be hummus, it can be whatever you like, as long as it's small enough so you make sure that the child will eat it. Once you open the capsule, you lose about half of it because you cannot squeeze it all out, and the shell does not protect it from the acid in the stomach. So in those cases, I would tend to use double the dose for that. Many times I get the following 2 questions. since you asked. One is, how much more can I give? And my answer is from my old compatriot Hippocrates, who said that too much is not necessarily good. Okay? So you really have to go slowly, but I always say you need at least 4 months before you see a difference. And the difference that we see starts with, if there are allergic problems, they disappear, or better eye contact, better sociability, and better following directions, so more complicated directions. So instead of bring the shoes to the bathroom. Okay? Language, in those children that do better, takes about a year or so, but I've had children who never spoke, and all of a sudden they speak just like us. So they don't learn one word at a time. The second question I get is, how long can I give it for? And I have 2 answers. One, I've been taking 6 a day ever since I made it, which is about 6 years ago. And my first child, who had started on this from Florida, he was 14. He was just admitted actually to a university in California, and he's still taking it. There's no downside, there's no major problem. So I usually tell parents, colleagues, if nothing works, at least you get Mediterranean diet in a capsule. Because the quercetin is from the pulp of the grapefruit, the luteolin is from the tea chamomile, and then it's olive oil. So, the only thing to keep in mind is if you push too many capsules too quickly, about 15% of the children who are very hyper, and they become even more hyper when they eat chocolate, they become more hyper because they have phenol intolerance. If I suspect that, then you can do genetic analysis for the enzymes that break down phenols, and then you can adjust the dose.
Thank you so much.
Oh, there's one more, I guess.
Dlaczego na niektóre dzieci dorosłych działa melanina?
Why melatonin does not work when this dose?
Melatonin.
Why melatonin?
Why melatonin doesn't work on some people?
In 40 years in medicine, no drug, no supplement works with everybody. Okay? And in fact, melatonin doesn't work with many people, including adults. So, 2 things about melatonin. First, I start with 1 milligram, and then I can give a second dose up to 3 milligram, usually 2 hours before a child is about to sleep, because it resets the clock. So you don't give it if you expect someone will go to sleep in 5 minutes. If it does not work, then I use, especially if there are allergic problems, hydroxyzine, because it's very sedating and it puts you in a very deep sleep as well. Between the two, most everybody does well. Now, even though we've been talking about supplements and some drugs, I did not mention anything about antipsychotic drugs. If a child is self-destructive, bites themselves, they break everything, they hit their heads on the wall, then I will give them, for at least 3 months or so, some antipsychotic drug, like Abilify or Risperdal, just to calm them down and allow the rest to help. Usually, those drugs are sedating as well. But as I said, I would only use them if a child really needs them and for a short period of time.
One more question from the lady. Why ibuprofen is recommended and not paracetamol?
Why ibuprofen is recommended, not paracetamol?
Okay. Well, first of all, ibuprofen is anti-inflammatory. Paracetamol is a pain suppressant. Of course, you can have pain because of inflammation, but paracetamol is not anti-inflammatory. If there's high fever, I will bring the high fever down quickly because high fever opens up the blood-brain barrier. But that's why ibuprofen.
But also there were some studies that actually paracetamol could be connected to autism. These studies were done in Edinburgh.
I didn't want to say that. Yes, you're right. She's right.
Jeszcze raz, jak długo było podawane ten lek, jak grupa
Jaki lek?
neurotoksyn?
Oh, she's asking about neuroprotect.
Yes.
How long it was supplemented to children, in what dose, and how children would react to it?
As I said earlier, the published studies were done for 6 months. The children that I have been dealing with take it for as long as they get benefit. If they continue to get better, even though they get better because of other interventions, such as speech therapy and work therapy, etc., I just continue to give it. The only time I would stop it is if a child becomes hyperactive, and what I mean by hyperactive, they will jump up and down like all day long, because many of us, we're hyperactive and playing around, etc. So we have to really make sure what I mean by hyperactive, where if a child is turning up and down the lights, all the time, that's what I would call hyperactivity. Then I would slow down, stop it maybe for a week, and then go 1 every 3 days, 1 every 2 days, 1 every day, and usually in 2 weeks you can actually build it up again.
I ostatnie pytanie.
Mam pytanie jeszcze, dlaczego czasem luteolina szkodzi, czyli powoduje właśnie nadaktywność i czy w sprawach, które się nazywa giaria, czy to jest też właśnie choroba luteoliny, czy w momencie, kiedy właśnie ją podasz, właśnie mamy właśnie do czynienia z nadaktywnością. Właśnie, czy podawać dalej, czy przerwać?
Pan możesz przetłumaczyć?
Why in some cases luteolin
It's causing
gives
hyperactivity.
hyperactivity, and
then
it should be dosed.
It should be continued or discontinued.
As I said, all flavonoids are phenolic. The more hydroxy group you have, the more phenolic you are. For instance, resveratrol, which is found in red wine, has 15 phenolic groups. Quercetin has 5, luteolin has 4. So it's important to use luteolin because it has the fewer phenolic groups, and don't necessarily combine it with other supplements that are also phenolic. Curcumin is phenolic, paracetamol is phenolic, so it is the combination of all of those that makes things worse. If, however, a child just cannot tolerate it at all, then you just have to stop it. But usually if you go slow, you overcome it. Now, in about 5 months or so, there will be another supplement that I do not have time to talk about that does not have phenolic groups. It's tetramethoxyluteolin, and no one will have any problem with that. But in order to allow children to tolerate it, there is also the so-called low phenol neuroprotect, that it has less quercetin, because quercetin is more phenolic. Okay, I have to run to the airport, so thank you very much.
Thank you very much. Hello, Taxi. Safe travels.